Okay, going to be doing our cardiac arrest management for CLS201. Okay, so we've arrived on scene. Our patient is unresponsive. We do our AVPU score, squeeze the shoulders, they're still not responsive. So now we're going to check for a pulse. Patient has no pulse and is not breathing. So we're going to get our partner to call for backup and we're going to commence CPR. So we're going to commence CPR at a rate of 30 to 2. So 30 compressions, 1/3 the depth of the chest, right on the sternum. We're going to continue doing that. Our partner's going to be doing that, sorry. And then we're going to be setting up our oxygen. So setting up our oxygen, getting it ready. Then we're going to give 2 breaths. So we're going to give 2 breaths via bag valve mask. That's done. Now we're going to go through a coached, an acronym. So our partner's going to continue compressions. Our oxygen is away. Now we're going to do hands off. Check the rhythm. So it is AF, so which means we're going to do 200 kilojoules. So oxygen's away, hands are off, shocking. We've shocked the patient. Okay, so now we're back into doing our anacronym. So our partner is doing the compressions. Now while they're doing compressions, we're going to set up airway management. So we're going to be putting in an iGel or an OPA. So at this stage, an iGel is going to be most appropriate. So we're going to be at the head of the patient. I'm so sorry. So we're going to be putting it in so we feel that firmness, putting it straight in to get airway management. So that is in our patient there. By that time, another coach will be coming around. So we're going to do continued compressions, oxygen away, all others clear, hands off. This is our second rhythm. It is still AF, so we're going to give 200 kilojoules again. All else clear, shocking. So shocked our patient, still nothing. Continue compressions. So our partner is continuing compressions while we are going to set up IV access so we can get some adrenaline into these veins. So I don't know if we're meant to actually do the actual parts where putting IV up, putting in the iGel or the actual cannula, but I'm just going to pretend anyway. So we've got some veins. We're putting in the cannula. Beautiful. So by that time, putting the cannula, we're going to be doing another round of coached. So continue compressions, our oxygen. Oh, we're going to be putting our breaths obviously in. 2, and then we're going to be doing coach. So continue compressions, oxygen's away, all others clear, hands off. Our second rhythm is still AF, but this time after the third round we give 360 joules, and that's what we do from now on. So shocking the patient. My partner's going to continue compressions. So while they're doing that, I'm going to give the patient some some adrenaline, through IV. We're going to be giving them, my bad. We're going to be giving them 1 mil in a 1 in 10,000 mil in a 10 millimeter syringe. So we're going to pump that straight through their veins. Done. Now we're going to repeat that every 2 cycles of a coached. So we're going to continue compressions. Going to run through another coach, so continue compressions, oxygen is away, all others clear. Again, we're going to shock them again, we're still in AF, so we're going to do that again. This time, after we've given 2 rounds of IV, we're going to give the patient now amiodarone to try and get their heart rate going in a normal rhythm again. So we're going to give 300 mils of amiodarone. Once and on that, another round of coaches coming up. Continue compressions. Oxygen's away, all others clear, hands off. But this time we have got ROSC, normal sinus rhythm. So we're not going to shock. We're going to dump the shock. Dump the shock. Now in this case we've got ROSC. We are not going to be giving any more amiodarone. We're going to be giving them an infusion of an adrenaline infusion and a fluid infusion to try and get this body stable. Now that this body is stable, we're going to be doing a 12-lead ECG, but at this time we'll probably be on our way to the hospital, trying to figure out what's wrong with this patient to make sure it doesn't happen again now that they're stable. Once we figure out, we can figure out based on the way whether they have a ST elevation or what's wrong. They might have a blockage. In some cases they can thrombolize the patient, but in most cases in metropolitan we'll probably bring them to hospital before we have time to even do that anyway. But in rural areas we may be authorised to have a call and get that one underway. that should be it. Thank you.